To present Dr. Christopher Girat. Dr. Christopher is a professor of medical oncology, Division of Cancer Medicine, University of Texas, MD Anson. Dr. Christopher's presentation will be on cascade of treatment in patients with metastatic breast.
I think my file size was too large, so too many pictures. But anyways, we're going to talk about a rare form of sarcoma, gastrointestinal stromal tumors. There's about 8 to 10,000 sarcomas a year. We don't know how many are gastrointestinal stromal tumors. Perhaps half of those are about 5,000 in the United States. So the incidence is very low. But now that we have targeted therapies, doctors are more on the lookout, so I think we're probably going to see increased incidence. Previously, they were called leiomyosarcomas because morphologically they look indistinct. They're hard to distinguish. The term gastrointestinal stromal tumors was only coined in 1984. So they can either present acutely with a rupture or diverticulum or intussusception or shock with perforation, or they can just bleed and you can get iron deficiency anemia. Predominantly these come from the stomach, but they can be found anywhere along the gastrointestinal tract, including rarely the esophagus and the rectum. So here's a picture of what they look like on CT. They're submucosal, so sometimes the endoscopist will miss them, and even if they do a mucosal biopsy, can be normal unless they do a full thickness biopsy. They do enhance on CT. They're very contrast avid, as well as on MRI. You can see them enhancing here in the stomach, and they tend to be PET avid. Tumors that are heterogeneous have a worse prognosis, and you can see here where the PET avidity is heterogeneous. Rarely, and in contradistinction to leiomyosarcomas, they rarely go to the lungs, whereas leiomyosarcoma, that would be the first place you'd see. Less than 5% of the time do we see lung metastases. And this is just an example of an acute presentation with intussusception and necrosis of the bowel. Now, interestingly, even though they're aggressive tumors, patients can have a high burden of abdominal peritoneal disease, but be relatively asymptomatic. We wouldn't see that with pancreatic cancer or colon cancer. Pathologically, they look benign. In fact, were called benign tumors in the past. They have usually a low mitotic rate. They can either be spindle cell, which is the majority here on the right, or they can be epithelioid, or they can be mixed. The hallmark is they do stain for c-KIT CD117, and they also stain with a vascular marker CD34. Now, even they believe, we're not sure the cell of origin, but the islets of Cajal, which are the pacemaker cells of the gut, they also stain both with vascular markers and c-KIT, so we believe they're probably the cell of origin. Now, despite us saying they look benign, they don't behave benign. They have a high metastatic potential, and that is linked to the size of the tumor as well as the mitotic rate. So it was interesting, Hirota first described a family of hereditary gastrointestinal stromal tumor and did full genome sequencing, and they found that there was an exon 11 mutation in the KIT oncogene, and they went and looked at sporadic GISTs, and the majority of them did have mutation. Most of them were in the KIT oncogene, and the majority of them were in exon 11, but it can occur at different sites. So this began looking at KIT as a potential target, as an activating mutation for these tumors. KIT is a cell surface receptor, but is important in many downstream pathways. And as you're aware, the drug imatinib, which was predominantly designed as a BCR-ABL inhibitor, also fortunately inhibits KIT. So initially they treated one patient in Finland. They weren't allowed to treat them in the United States due to regulatory issues, but they treated one patient in Finland with metastatic GIST with a good outcome based on PET, and this led to a randomized international trial of 2 dose levels. And this is just to give you an idea of the dramatic effects that you can see with treatment with a pill that's relatively benign. I have to say, there's a long interval between these scans, and you can see responses, but responses don't occur early. Usually patients, their abdomens will become softer very quickly, and they will develop improvement in their symptoms, but it can take months before you see a response. And in fact, there is a condition called early progression. You'll see here where in the original tumor, I'm not sure if I can point this out with the arrow, but there's central necrosis with decreased CT attenuation. But as you treat it and it becomes more fibrotic, you get lower contrast enhancement at the periphery, and you get lower CT attenuation. And that can sometimes lead to the development of supposedly new lesions, but that's due to a change in the CT attenuation. So you have to be careful about early progression. This is another example where a new lesion appeared, but when you look back in retrospect, there probably was something there, but with the change in attenuation, it became more evident. There's another concept. Sometimes when people become, the tumors become fibrotic, at time of progression, the tumor cannot increase in size, but they can develop progression inside of the cavity. Okay, my markers disappeared here, but you can see here where there's growth of tumor inside of the previously fibrotic cavity. So the one good thing about sunitinib, it had very little toxicity, and in fact, in this trial, somewhat unusually, they opened it up to patients with ECOG performance status 3. So people could be very, very sick, bedbound, unable to do any activities of daily living, and still qualify for benefit with this agent. The main side effects we think are related through the PDGF pathway, which it also inhibits. They can get ascites, peripheral edema, and periorbital edema. I have an example here of a gentleman with some periorbital edema. I'll also mention that the surgical treatment of GIST, which I think someone else is going to address, is principally, if it's local treatment, you should do surgery. But in some cases where surgery is borderline, neoadjuvant KIT inhibition therapy is certainly an option. This person was deemed to be resectable but would require a total gastrectomy. It was an elderly patient and got neoadjuvant GIST, had an exon 11 activating mutation, and ended up with a subtotal gastrectomy. So this is an original trial. The majority of the patients did have a KIT mutation. This is the response rates, but you'll see that there still are response rates even if you have wild-type tumors, and presumably that's mediated through the PDGF pathway as for anti-angiogenesis pathway. This is important. It shows that for imatinib, the patients that do the best are exon 11 followed by exon 9. So they did do a randomized phase 2 looking at 2 dose levels, and overall there wasn't a statistically significant difference in the 2 different dose levels, although there was a difference in progression-free survival in favor of the higher dose level. This gives you an idea of what this is compared to what our standard of care would be with just doxorubicin, significantly improved survival. These aren't randomized arm, but this is a historical data. One thing that's important is that patients with exon 9 mutations seem to do better with the higher dose of imatinib. And for those, if they progress, utilization of the 800 milligram dose is perhaps indicated. So this, so upon progression, we had no good treatment, but there is a second generation KIT inhibitor, and it also inhibits vascular endothelial growth factor pathway as well as PDGF. It's the drug sunitinib malate, and it was looked at in phase 1 studies and did have some preliminary activity in renal cell. You heard earlier it had some activity in neuroendocrine tumors as well as gastrointestinal stromal tumors. So they did a trial of patients who were imatinib refractory or intolerant, and they did see activity. So they moved on to a randomized phase 2 trial, which to maintain equipoise, there was twice as many people in the sunitinib group, but they did allow for crossover in this trial at time of progression, which may obscure an overall survival benefit to sunitinib. So the main toxicities you heard about sunitinib are fatigue, but it also can cause plantar palmar dysesthesias. It has this strange toxicity where patients develop a yellow appearance. And it also, with chronic exposure, can lead to hypothyroidism. So checking a sensitive TSH at every 2-month intervals is recommended. So this is a patient who is intolerant of imatinib and was treated with sunitinib with a major reduction in her peritoneal sarcomatosis. And this is another example of a patient who was imatinib resistant, initially responded, but then was resistant and responded to sunitinib. And again, another example of someone with peritoneal sarcomatosis and ascites with decreased disease burden with sunitinib. So you can see responses, although uncommon. This is in the second-line setting, but more commonly we see stable disease. So because of the one other point was that when they looked at mutation analysis at their time of progression, tissue acquisition was required, and at time of progression, those with an exon 9 mutation appeared to derive greater benefit. They also looked at the time of the original tumor, and similarly this held out that the benefit seemed to be predominant, was greater with those with an exon 9 mutation. And because this was crossover, they weren't able to show survival benefit, but they did some fancy statistical analysis where they looked at the placebo arm up until the time patients crossed over, and they were able to, from that, determine what the survival would have been without crossover. And this is, with this statistical modeling, they were able to show that there would have been a survival benefit if it wasn't for a crossover. There is another drug, nilotinib, which is a second-generation KIT inhibitor, which showed some activity in phase 2 trials, but in a phase 3 randomized study, did not show a benefit in progression-free survival. So there's another drug, as you know, approved for colorectal cancer, regorafenib, which has multiple targets you can see here, but based on its toxicity, the predominant method of action is through the vascular endothelial growth factor pathway. And it showed activity in both imatinib and sunitinib refractory patients with responses seen. This led to a randomized phase 3 study where there was an overall progression-free survival advantage in favor of regorafenib. Again, because of crossover, overall survival benefit couldn't be analyzed. So this drug is now approved in the third-line setting. This is the PFS and overall survival curves. So now, treatment of gastrointestinal stromal tumors is rather crowded, and there's a whole bunch of targeted agents people are looking at. They're looking at mTOR inhibitors. They're now looking at immunotherapy, heat shock protein inhibitors, and IGFR1 inhibitors. These are all in play looking at patients in the fourth-line setting now. So that the take-home message is, I think the diagnosis of GIST can be difficult for pathologists, so we would routinely recommend mutation analysis up front. Confirm the diagnosis also helps guide treatment, although we're not recommending sunitinib up front. Certainly people with exon 9 mutations, we're looking at high-dose imatinib or moving them to sunitinib, looking out for progression. Patients with wild type or PDGF mutations may still derive benefit from KIT inhibitors. And down the line we have sunitinib and regorafenib. For patients who fail all these, there's been some reports of a re-challenge with imatinib in the fourth-line setting with stable disease. At the time of rebiopsy, they're finding different clones are being selected out through these treatments, and they're seeing patients with, sometimes they're calling them acquired second mutations, but they're actually probably selection of clones. So some people are having both PDGF and exon 11 KIT mutations, and therefore may benefit from retreatment with the imatinib. Thank you very much.
Thank you, Professor Christoph, for this elegant presentation of GEST. We'll postpone the discussion to the end of the session. Now I am honored to present